6.6 Video, Bilateral Vestibulopathy, Prognosis, Future Directions, and Gene Therapy, Vestibular Physician.
Welcome to the sixth and final explainer in our series on bilateral vestibulopathy. We've covered a lot of ground, and today we're bringing it all together to look at the long-term clinical trajectory of these patients.
Here's our roadmap for today. We're going to cover prognosis by etiology, tackle the very real falls risk, dive into some current diagnostic controversies, unpack the Canvas paradigm shift, and finally, look at some genuinely exciting future tech like vestibular implants. Let's get right into it.
Starting with Section 1, Prognosis by Etiology. Because right out of the gate, we have to understand that the long-term outlook for a BVP patient is absolutely not uniform. It completely depends on the underlying cause.
Now, the somewhat sobering reality we have to face is that spontaneous vestibular function recovery in established BVP is extremely rare. Basically, once those delicate hair cells are destroyed, whether that's by ototoxicity, infection, or just degeneration, structural restoration just doesn't happen in humans on its own. So once that loss is established, our clinical mindset has to shift. We're no longer looking for anatomical recovery, we're focusing purely on rehabilitation, sensory substitution, and just maximizing whatever functional capacity the patient has left.
And you can really see how these prognostic trajectories split based on the cause. For instance, with aminoglycoside ototoxicity, if you catch it early and stop the drug, you can actually see partial recovery in about 20 to 30% of patients. Autoimmune disease is even better, offering a remarkably high 60 to 70% partial recovery rate if you hit it promptly with high-dose steroids. Idiopathic cases, they're mostly stable, though about 10 to 20% will eventually progress. But then you look at Canvas. That is a strictly progressive decline with compounding ataxia, and unfortunately, it often leads to wheelchair use within 10 to 15 years.
Which brings us to Section 2, Falls Risk and Morbidity. This is the single most significant real-world daily threat for any patient living with established bilateral hypofunction. Prospective data shows us that the fall rate for BVP patients is actually 3 to 5 times higher than their healthy peers. We're talking about an annual rate of 0.8 to 1.2 falls per patient year. Because they've lost that crucial vestibulospinal reflex, the one that drives rapid postural muscle activation when your head moves unexpectedly, their baseline physical stability is just severely compromised. And this is why we can't just treat the dizziness in a vacuum. A 3 to 5 times higher fall rate translates directly into a massive increase in fracture risk, particularly those devastating hip and Colles fractures in older demographics. For a patient who is already struggling with a disability, a catastrophic fall like that can literally end their ability to live independently. So things like environmental assessments, putting in non-slip flooring, ensuring really good nocturnal lighting since they rely so heavily on their vision, and strictly eliminating evening sedating meds, these aren't just polite suggestions for the patient. They are absolutely mandatory clinical interventions.
Moving on to Section 3, Current Clinical Controversies. Because despite knowing all these risks, our field is actively debating how we even classify these patients in the clinic. It's a classic specificity versus sensitivity debate around the 2017 Ronnie Society diagnostic criteria. On one side, we have high specificity. The criteria are stringent, requiring a V-hit horizontal gain below 0.6 and a BIF thermal caloric summed slow phase velocity below 6 degrees per second per ear. That basically guarantees we are diagnosing true, complete failure. But on the flip side, you have advocates pushing for clinical sensitivity. They argue, and rightly so, that these strict thresholds might actually abandon patients who have partial loss but are still suffering from real, disabling functional deficits. It's a huge ongoing debate about whether we need to introduce graded classifications for partial BVP. And that leads us to this incredibly provocative question that is challenging neuroetology right now. Does idiopathic BVP even remain a valid diagnostic category if you haven't explicitly tested the patient for the RFC1 gene mutation?
That question takes us directly into Section 4, the Canvas paradigm shift. This is easily the most important recent advance in identifying the true root cause of BVP.
Discovered just back in 2019, Canvas stands for cerebellar ataxia, neuropathy, and vestibular areflexia syndrome. Figuring out that this is caused by a highly specific genetic mutation, the biallelic AAGG intronic repeat expansion in the RFC1 gene, has just completely flipped the epidemiology of what we used to casually label as idiopathic. It finally gives us a definitive biological answer for a clinical presentation that used to just be a frustrating dead end.
What's truly fascinating but also really tragic about Canvas is that it causes a triple sensory deafferentation.
Normally, when you lose vestibular function, your brain compensates by relying heavily on vision and proprioception. But Canvas strips away those backups. It causes bilateral vestibular areflexia, but also large fiber sensory peripheral neuropathy that wrecks proprioception, plus cerebellar vermian degeneration that leads to ataxia. It systematically dismantles every compensatory mechanism the patient has. Because this specific mutation accounts for an estimated 10 to 20% of previously unexplained cases, the diagnostic landscape has totally changed. Current expert opinion practically demands genetic testing for anyone presenting with unexplained bilateral areflexia, especially if you see any neuropathic features or cerebellar signs. The days of just shrugging and writing idiopathic on the chart without checking for this genetic marker are over. So, Section 5. If recovery is rare, and things like Canvas are progressive, what hope do we actually have for complete areflexia? Well, the answer is coming from some incredible bioengineering.
Enter the vestibular implant. Modeled directly on the massive world-changing success of cochlear implants, this is an extraordinary neural prosthetic. Basically, it detects angular head velocity using a tiny gyroscopic sensor, encodes that physical motion into patterned electrical pulses, and then delivers that electrical stimulation directly to the ampullary nerves. It is essentially stepping in to provide a real-time synthetic reflex where the natural hair cells have failed. And when you look at the timeline of clinical translation, the progress is just staggering. We went from early animal models in the 90s to human trials today that are showing genuine, measurable restoration of a prosthetic VOR, better stability, and reduced oscillopsia. There was even a 2023 study by Della Santina's group proving the implant works in patients who had been completely without vestibular function for over 20 years. No joke, we are probably just 5 to 10 years away from making these implants a standard clinical reality. And in the background, we've got parallel research into gene therapy and RFC1 antisense oligonucleotides that might actually treat the biological root causes in the future.
Now, a quick caveat. Right now, the candidacy criteria for these trials are very strict. To qualify for experimental use, a patient needs confirmed bilateral areflexia with a VOR gain approaching absolute zero, significant disability even after maxing out conventional rehab, and they can't have a cochlear implant that might physically block the new electrode array. Keep these criteria in the back of your mind when you're evaluating which of your refractory patients might be good candidates to refer to a research active neuroautology center.
All right, let's wrap this up with Section 6, Key Clinical Takeaways. Let's distill down the absolute most critical points from this whole explainer.
I love this quote from the recent literature. The two most important practice-changing advances in BVP of the past decade are RFC1 genetic testing and the vestibular implant. That really hits the nail on the head. It perfectly summarizes the real-time shift we are living through right now, moving away from just diagnostic uncertainty and symptom management and directly into an era of precise genetic identification and true technological restoration.
So to summarize your core clinical takeaways, always remember that prognosis is fundamentally dependent on the etiology. Mitigating that 3 to 5 times elevated falls risk is non-negotiable. Don't write off patients with partial but disabling loss just because of strict thresholds. Always audit your idiopathic cases for Canvas. And finally, know that vestibular implants and gene therapies are the definitive future of our field. With genetic screening reclassifying our patients today, and vestibular implants poised to physically, synthetically restore balance tomorrow, it leaves us with an amazing, provocative thought. Are we currently treating the last generation of patients who will ever have to live with permanent bilateral vestibular loss? Visit AustralianDizzinessClinics.com for the full literature review and clinical resources.